Welcome to Vet NeuroJar, the podcast dedicated to keeping your equine companions happy and healthy. Today we will be discussing vitamin E and selenium deficiencies in horses. These deficiencies can lead to significant health challenges, making this a vital topic for horse owners. Vitamin E and selenium are essential for equine health, working to ensure proper function. Let's start with understanding what these nutrients are and their importance for horses. Vitamin E deficiency develops in horses consuming grass hay rations and that do not receive additional supplementation. Selenium deficiency occurs in horses that consume either dried forage or green grass diets when either forage source is produced in regions where soil is deficient in selenium or vegetation uptake of selenium is impeded. Individual animal factors can increase the need for antioxidant protection, which may exacerbate dietary deficiencies. Clinical signs arising from these deficiencies can be very severe and challenging to completely resolve. Hence, prevention of these deficiencies is critical in equine nutritional management. Vitamin E and selenium deficiencies can lead to distinct clinical disorders, and both nutrients should be assessed and managed independently. Vitamin E is an essential fat-soluble vitamin that is required for healthy neuromuscular function. Vitamin E was originally a general term used to describe a family of 8 naturally occurring closely related compounds. Alpha-tocopherol, specifically the natural RRR stereoisomer, is the most bioavailable and bioactive form in animal tissues due to preferential uptake by the liver. Since alpha-tocopherol is also the most potent antioxidant and the only isoform that, when deficient, leads to disease in humans, a recent proposal suggests renaming vitamin E to include only alpha-tocopherol. Thus, the terms alpha-tocopherol and vitamin E should be used interchangeably. The major dietary source of vitamin E for horses is fresh pasture, optimally providing approximately 30 to 100 international units per kilogram dry matter of vitamin E. With forage consumption for a healthy, mature horse estimated at 2% body weight per day, this equates to 300 to 1,000 international units of vitamin E consumed by a 500 kilogram horse per day. The Nutritional Research Council lists maintenance requirements of vitamin E for mature horses as 1 international unit per kilogram body weight, that is 500 international units for a 500 kilogram horse, which is easily met when horses are grazing on fresh pasture multiple hours per day, but green pasture may not be available year-round. Storing of forage leads to degradation of vitamin E, with losses approaching 50% in alfalfa hay stored for 1 month. Commercial feeds usually provide vitamin E in the form of synthetic vitamin E, containing a mixture of 8 isomers, of which only 1 is identical to the natural isomer. This form of vitamin E is a less bioavailable formulation than natural vitamin E. Thus, horses maintained on hay and grain receive far less than the recommended daily requirement of vitamin E. Whole body deficiency of vitamin E is typically assessed by measuring serum concentrations, with normal equine serum concentrations considered to be greater than 2 milligrams per milliliter. However, based on studies of horses maintained on pasture, target serum vitamin E concentrations between 3 and 6 milligrams per milliliter are recommended. For the assessment of blood vitamin E concentrations, either serum or plasma can be sampled, and concentrations are linearly correlated. However, for longitudinal assessment within one horse, either serum or plasma should be used each time to avoid the slight variability that can occur between sample types. Vitamin E concentration in serum is slightly higher than in plasma. Deficient horses may have larger fluctuations in serum vitamin E than non-deficient horses within a 24-hour period. Despite these fluctuations, horses with normal vitamin E concentrations tend to maintain values within normal reference intervals based on multiple samplings over time. Deficient horses tend to stay deficient throughout a 24-hour period. Thus, a single sample is typically sufficient to assess serum or plasma vitamin E status. When evaluating serum or plasma vitamin E concentrations, hemolysis should be avoided since it can decrease vitamin E concentrations by up to 33%. Blood tubes should be stored upright to prevent contact with the rubber stopper and should be stored refrigerated to prevent artificial decreases in vitamin E concentration. In humans, serum or plasma vitamin E concentrations are only 1% of total body stores, and blood concentrations may not reflect tissue concentrations. Thus, in some cases, tissue vitamin E concentrations could be a better marker of whole body vitamin E status than serum or plasma concentrations. In healthy horses, plasma and adipose tissue concentrations and plasma and hepatic and muscle concentrations are linearly correlated. However, this is not the case in vitamin E-responsive myopathy. Across species, clinical vitamin E deficiencies primarily target neuromuscular tissues. Although white muscle disease has been associated with vitamin E deficiency, the primary cause is actually selenium deficiency. There are currently 3 diseases recognized as associated with vitamin E deficiency in horses: equine neuroaxonal dystrophy or degenerative myeloencephalopathy, equine motor neuron disease, and vitamin E responsive myopathy. When assessing myopathies associated with vitamin E deficiency, a biopsy of the sacrocaudalus dorsalis medialis muscle is required, since it contains a high proportion of the oxidative type I fibers that are affected by long-term vitamin E deficiency. Gluteal muscle biopsies are unlikely to demonstrate any pathology. In the sacrocaudalus dorsalis medialis muscle, characteristic histopathologic changes are identified with equine motor neuron disease and vitamin E responsive myopathy in type I myofibers consistent with vitamin E deficiency. With equine motor neuron disease, older horses are often vitamin E deficient for 18 months or more, with clinical signs of weakness and neurogenic muscle atrophy. Adult horses with vitamin E responsive myopathy can present with muscle atrophy, weakness, and low muscle vitamin E concentrations, but these horses have mitochondrial alterations in muscle fibers and a preponderance of anguloid atrophied fibers that have concavity more on one side, rather than neurogenic atrophy, which is characterized by angular atrophied fibers that are compressed into triangular shapes. With vitamin E responsive myopathy, vitamin E deficiency may be associated with poor performance. In affected horses, serum concentrations of vitamin E may be within the normal range, yet the horse will clinically respond to supplementation. It is hypothesized that these horses may not be able to transport vitamin E into muscle tissue normally, and therefore maintain a normal to high serum vitamin E concentration with deficient muscle concentrations. With classic equine neuroaxonal dystrophy or degenerative myeloencephalopathy, young horses do not have any pathologic changes of peripheral nerves or skeletal muscle. In older horses with equine neuroaxonal dystrophy or degenerative myeloencephalopathy, long-term vitamin E deficiency can lead to mitochondrial alterations in type I myofibers. Historical vitamin E deficiency can also be identified from retinal lipofuscin deposits. Therefore, mitochondrial alterations on a muscle biopsy, in addition to retinal lipofuscin deposits, may provide support for historical vitamin E deficiency, but both appear to be age-dependent. To correctly supplement vitamin E in the horse, the type and formulation of vitamin E supplements need to be considered. Natural vitamin E is more bioavailable than synthetic vitamin E, and therefore many equine supplements now strongly market the natural form. The natural formulation is available as an esterified form to prolong shelf life or as a water-dispersible formulation with higher biopotency. Most studies of vitamin E supplementation have used healthy horses and assessed serum vitamin E rather than neuromuscular tissue concentrations. The absorption and metabolism of vitamin E in healthy horses may differ from that of horses with diseases associated with vitamin E deficiency. As a result, it is essential to measure serum vitamin E concentrations, monitor vitamin E concentrations, and adjust the dose in response to changes occurring with supplementation. The most rapid rise in serum vitamin E concentrations is obtained by providing natural source liquid forms of alpha-tocopherol at 10 international units per kilogram body weight. The liquid formulation is 5 to 6 times more bioavailable than synthetic alpha-tocopherol acetate, and a 5,000 international unit dose per horse more than doubles serum vitamin E concentrations within 12 hours. Evaluation of healthy horses with marginal or deficient serum vitamin E concentrations found that 14 days of water-dispersible natural alpha-tocopherol supplementation at 10,000 international units per horse per day significantly increased cerebrospinal fluid alpha-tocopherol concentration. However, there is rarely the need to administer more than 5,000 international units per horse per day of water-dispersible alpha-tocopherol, since more recent evidence has demonstrated an increase in cerebrospinal fluid alpha-tocopherol at this dose. Many owners are reluctant to maintain horses on liquid supplementation long-term, and therefore, changing to a powdered or pelleted supplement is often desired. However, veterinarians should be aware that when horses are switched from the same dose of natural water-dispersible vitamin E to the powdered acetate formulation, a precipitous drop in serum vitamin E can occur. The most effective and economical approach to supplementing deficient horses over time is therefore to overlap treatment with the liquid and powder or pellet formulations and gradually withdraw the liquid vitamin E, leading to a more stable steady state of serum vitamin E and higher tissue vitamin E concentrations with continued supplementation. If horses are deficient in vitamin E without signs of neuromuscular disease and owners find water-dispersible formulations of vitamin E cost prohibitive, supplementation can be started with 5,000 international units per day of pelleted or powdered natural alpha-tocopherol acetate. However, serum vitamin E concentrations are not expected to increase for at least 8 to 10 weeks using this protocol. Approximately 40% of equine motor neuron disease cases may demonstrate some improvement within 6 weeks of appropriate supplementation, and some can appear normal within 3 months. In cases of equine neuroaxonal dystrophy or degenerative myeloencephalopathy, vitamin E supplementation does not improve clinical signs, but may stabilize the disease process. However, vitamin E supplementation of genetically susceptible foals throughout the first year of life can decrease the overall incidence of signs of equine neuroaxonal dystrophy or degenerative myeloencephalopathy. Horses with vitamin E responsive myopathy respond well to appropriate vitamin E supplementation and can regain strength and muscle mass within 3 months. It is noteworthy, however, that in clinically normal vitamin E deficient horses with mitochondrial alterations in the sacrocaudalus dorsalis, medialis muscle, vitamin E supplementation does not change the percentage of fibers with mitochondrial alterations or anguloid atrophy. Repeatable success has been demonstrated when using an alpha-tocopherol liquid formulation for supplementation at the doses recommended in this article. There are, however, a subset of horses that fail to respond to correctly supplemented alpha-tocopherol. These horses may have malabsorption due to inflammation from parasitic infections or other causes of gastrointestinal inflammation. There is no approved injectable vitamin E product for horses that will effectively raise serum vitamin E concentrations. The only currently available product for horses that is approved will increase selenium concentrations, but does not provide enough bioavailable alpha-tocopherol to affect serum alpha-tocopherol concentrations. While many nutrition companies tout their products as containing natural vitamin E, most have not been assessed in clinical trials. For that reason, careful consideration of both product type and dose must be given when targeting vitamin E supplementation in deficient horses. For large herds, the most cost-effective means of supplementing horses is to provide fresh pasture for at least 6 months of the year. Where this is not an option, targeted supplementation as recommended is advised. Assessing serum vitamin E concentrations in individuals is paramount since vitamin E metabolism differs widely from horse to horse. While vitamin E supplementation is generally considered safe, there are potential risks of oversupplementation. Supplementation with vitamin E may alter drug metabolism and disposition since, in humans, the same cytochrome isoforms that metabolize vitamin E metabolize greater than 50% of therapeutic drugs. The Nutritional Research Council has set the upper safe dietary concentration for vitamin E based on biopotency of synthetic alpha-tocopherol. Above this level, coagulopathy and impaired bone mineralization have been reported. Therefore, regular assessment of serum vitamin E concentrations is highly recommended in supplemented horses.
Selenium is considered an essential trace mineral and a rare and non-renewable global resource, critical to human and animal health and utilized extensively in a range of global industrial processes. Selenium has critical antioxidant functions mediated through multiple selenium-dependent peroxidase enzymes, and selenoproteins are also integral in immune function, reproductive success, and muscle and thyroid function. Inadequate dietary intake of selenium is the cause of selenium deficiency in humans and animals. Low soil selenium content is a major factor contributing to the production of selenium-poor forages, exacerbated by factors interfering with selenium uptake by plants, including the application of phosphate or sulfate-containing fertilizers. Selenium-deficient soils are found in large regions of the world, including much of the United States, as well as regions of Canada, Australia, New Zealand, and Europe. Furthermore, consumption of sulfur, copper, and other elements can impede gastrointestinal absorption of selenium by animals, and animals under physiologic stress, such as during pregnancy, lactation, heavy exercise, or growth periods, may have increased antioxidant requirements, including higher selenium needs. Due to concerns for human and animal toxicity risks, selenium content of animal feed products is controlled, which limits the addition of selenium in certain forms. Selenium supplementation for horses is not formally recognized. However, equine nutritional products now often align with recommendations made for beef cattle. According to regulations, any of the listed selenium forms can be added to complete feeds at levels not exceeding 0.3 parts per million dry matter. To feed supplements for limit feeding not exceeding 3 milligrams total per head per day for beef cattle. or to salt mineral mixtures up to 120 parts per million for free choice feeding at a rate not exceeding an intake of 3 milligrams per head per day for beef cattle. Clinical evidence supports a minimum total intake of 1 milligram per day of selenium for a 500 kilogram horse, compatible with the Nutritional Research Council recommendations of 0.1 milligram per kilogram dry matter for mature sedentary horses. This amount will apparently maintain whole blood selenium concentrations within reference intervals for mature horses, even in deficient regions. However, depletion and repletion studies suggest that 0.1 milligram per kilogram dry matter is close to the minimum requirement for idle mature horses and may not be adequate to optimize blood concentrations, performance, or production. Providing selenium at 0.3 parts per million dry matter increases selenium status to a plateau significantly above that of horses fed at Nutritional Research Council recommendation. All contributions of selenium to the ration should be considered during dietary evaluation to avoid the potential for toxicity, which can result in hoof and hair coat abnormalities. A maximum tolerance has been suggested. Selenium sources that require voluntary intake, such as selenium-containing salt blocks, can be highly unreliable, and therefore directed feeding of minimum daily requirements is recommended to prevent deficiency in equids. All forms of selenium are well absorbed and suitable for prevention of deficiency in horses, with perhaps slight superiority of selenomethionine yeast. In utero, foals derive selenium across the placenta and hence deficient mares, and occasionally mares with adequate blood selenium concentrations can produce foals with subclinical or clinical selenium deficiency. Deficiency in either mare or foal should be considered evidence of likely deficiency in the other as well as in herd mates. Selenium and vitamin E interact as antioxidants, and there is evidence to suggest that adequate status in one nutrient can confer some protective effect when the other is deficient. However, severe clinical selenium deficiency, including cardiac damage, can occur in neonatal and mature equids even in spite of adequate vitamin E status. And ideally, both nutrients should be assessed when clinical signs and management factors suggest deficiency of either nutrient. Mature horses likely sustain suboptimal blood and liver selenium concentrations for months before the onset of overt clinical signs of deficiency, and some individuals can be clinically asymptomatic in spite of very low blood selenium concentrations. However, it is likely that deficient horses go through a period of subclinical disease. During this time, they potentially have suboptimal immune responses and suboptimal reproductive function, with pregnant mares also at risk of dystocia, abortion, or producing foals with clinical deficiency. Clinical signs of deficiency are reported with the greatest frequency in foals and usually relate to the presence of severe rhabdomyolysis, referred to as nutritional myodegeneration or white muscle disease. Affected foals may be born with clinical signs or develop them days to months after birth. Foals may be recumbent or weak and may display low head carriage related to weakness and necrosis of cervical musculature. Visible myoglobinuria may be evident when large amounts of muscle tissue are compromised and secondary renal damage can occur. Cardiac arrhythmias may be evident related to accompanying myocardial necrosis or severe electrolyte disturbances associated with massive rhabdomyolysis. Signs related to disturbed oropharyngeal function, including milk from the nostrils and aspiration pneumonia, often occur, related to compromise to the musculature of the tongue and or pharynx. In Europe, severe panniculitis or steatitis is also reported to occur in foals and young horses, potentially related to combined deficiencies of selenium and vitamin E. Though foals have been suggested to be much more susceptible to nutritional myodegeneration, there are multiple reports describing severe clinical disease and death in mature equids as a result of selenium deficiency. The clinical presentation of severe and prolonged selenium deficiency in mature horses can be highly variable, often contributing to misdiagnosis and delayed recognition and treatment. The list of tissues that may be affected in selenium deficiency and the associated clinical signs that can be encountered as a result are included, and combinations of potentially any of these signs can arise in an individual. Clinical signs can present acutely, despite the chronic nature of the underlying disease, or subtle anomalies including diffuse muscle atrophy and abnormal prehension can develop over weeks to months, sometimes preceding an acute crisis of non-exertional rhabdomyolysis with or without accompanying indications of cardiac muscle damage. External stressors, such as moving environments, can precipitate the onset of overt clinical signs in chronically deficient horses. Clinical presentations of confirmed severe selenium deficiency in mature equids that have been reported in the literature and anecdotally observed include, and are not limited to, acute non-exertional rhabdomyolysis, diffuse severe chronic muscle atrophy and weakness, abnormal prehension with quitting of feed and trismus, oropharyngeal dysphagia, signs of left-sided and right-sided congestive heart failure with accompanying rhabdomyolysis, spontaneous ventricular tachycardia, respiratory failure, related to diaphragmatic necrosis and paniculitis. Multiple deaths can occur in groups of mature equids as a result of severe sustained selenium deficiency, particularly when the underlying cause is not identified promptly.
In clinically diseased horses, the diagnosis of selenium deficiency is usually supported by compatible dietary history and clinical signs, elevated serum creatine kinase and aspartate transaminase activities, and measurement of whole blood selenium or other blood-based indicators of selenium status. Additional diagnostics are typically focused on evaluating the presence and severity of the primary and secondary consequences of this deficiency. Subclinical selenium deficiency is very common in some regions, and confirmation requires blood testing. Suspicion for deficiency can be readily established by ration review, where the amount of each component fed and its reported or estimated selenium content are collated to determine if minimum requirements for the individual are likely being met. Generally, in deficient regions, forage, whether green or dried, should be considered a negligible selenium source due to low intrinsic selenium content, as should salt blocks, since highly variable and unreliable daily consumption patterns occur. Confirmation of suboptimal selenium status can be determined by measurement of several variables, including plasma or serum selenium, whole blood glutathione peroxidase activity, or whole blood selenium concentration. Extensive literature exists for all of these measures in horses, and measurement of whole blood selenium concentration is the preferred methodology to detect deficiency due to greater reliability of results and capacity to more accurately differentiate deficient from adequate status. Though serum or plasma selenium concentration more accurately reflects recent supplementation status, measurement of whole blood selenium is a good indicator of chronic supplementation status, and both are convenient in foals, where ration review has less utility. Mare and foal selenium status is moderately to highly correlated, and horse and donkey foals typically have lower plasma and blood selenium values than their dams, even when blood glutathione peroxidase does not differ. Nonetheless, mares with apparently adequate selenium status on blood testing can still produce clinically selenium-deficient foals, but do so much less frequently than mares with inadequate status. It is also possible to observe features suggestive of nutritional myodegeneration, particularly in the masseter muscles, in horses with apparently normal blood selenium status, suggesting complex etiology in some cases. Liver tissue can also be collected by biopsy or post-mortem sampling for measurement of selenium concentration as an accurate indicator of whole-body selenium status. Elevation of serum creatine kinase and aspartate transaminase activities are encountered in most cases of clinical selenium deficiency of foals and mature horses, and can vary widely from hundreds to hundreds of thousands, though values are rarely completely normal. Extremely high creatine kinase values and myoglobinuria indicate the presence of severe rhabdomyolysis involving a large amount of muscle tissue. Modest elevations can occur in chronically diseased animals that also have severe dysfunction, and anecdotally, there appears to be poor correlation between how high serum creatine kinase activities are and prognosis for survival. In cases with acute, profound rhabdomyolysis, additional biochemical disturbances can be encountered, including azotemia, hypoalbuminemia, hyperkalemia, hyperphosphatemia, and reductions in serum sodium, chloride, and calcium. In foals, this necessitates the exclusion of urinary tract disruption as a cause of azotemia and electrolyte disturbances by abdominal ultrasound and potentially peritoneal fluid analysis. Urine of equids with rhabdomyolysis should be evaluated for the presence of visible or occult pigmenturia and specific gravity recorded prior to fluid therapy if possible. Measurement of blood cardiac troponin I, in addition to electrocardiogram monitoring and echocardiography, can help establish the presence and severity of cardiac involvement in selenium deficiency cases, which has implications potentially for survival and future performance. Non-exertional rhabdomyolysis with cardiac involvement may necessitate additional diagnostic steps to exclude toxic etiologies, including ionophores and hypoglycin. For horses with masseter involvement, Other causes of trismus and masseter myodegeneration might require consideration, including hypocalcemia, hyperkalemic periodic paralysis, tetanus, and jaw trauma. Imaging via radiography and ultrasound should be considered. Dysphagic foals and horses may require endoscopy and other diagnostics for upper gastrointestinal and respiratory tract assessment. Ultrasonography has been used to confirm steatitis in horses with nutritional deficiencies reflected by abnormally increased echogenicity of adipose tissue, including in the perirenal, coronary, pericardial, and ventral extraperitoneal regions, and confirmed by adipose biopsy. Histopathology of skeletal muscle tissue can be used to identify patchy monophasic or polyphasic necrosis and dystrophic calcification suggestive of nutritional myodegeneration, and to exclude other causes of atrophy and/or non-exertional rhabdomyolysis, including vitamin E deficiency disorders and hypoglycemia toxicity. Where relevant, specific genetic testing can be used to exclude glycogen branching enzyme deficiency, myosin heavy chain myopathy, and type 1 polysaccharide storage myopathy, which can also all be associated with non-exertional rhabdomyolysis.
Rectifying the absolute deficiency is usually readily achieved by injecting affected equids intramuscularly with inorganic selenium at a dose of 0.055 mg per kilogram. This can be repeated in 7 to 10 days if very low blood concentrations are observed. Repeat evaluation of whole blood selenium 4 weeks after treatment commences is recommended. Where there is a high index of suspicion for deficiency, horses should be provided injectable selenium prior to return of results related to measurement of selenium status to optimize the chance of successful outcome. Due to the constellation of involved tissues in many cases, and the severity of clinical signs that can occur, it is not uncommon for affected foals and adults to require prolonged and extensive treatment, sometimes stretching over multiple weeks. Complete recovery can take months, and permanent fibrosis and atrophy of damaged musculature can occur. Treatment and monitoring of clinical deficiency cases should subscribe to the following tenets as necessary. Prevent progressive rhabdomyolysis, provide injectable selenium, oral dantrolene sodium, appropriate bedding, and sling support if necessary. Monitor serum creatine kinase and aspartate transaminase for response to treatment. Prevent recumbency-related complications, remove shoes, wrap limbs, protect head and eyes. Provide analgesia caution with non-steroidal drugs if renal challenges are present. Prevent renal damage from vasomotor phenomena and pigmenturia, fluid therapy, judicious use of nephrotoxic agents, and alkalinization if acid urine is present concurrently with myoglobinuria. Correct severe electrolyte disturbances. Provide nutritional support in animals with dysphagia, trismus, or anorexia. Parenteral and enteral nutrition may be necessary, or modified diets, along with protein and amino acid supplementation. Miniature horses, ponies, and donkeys in particular require careful management to prevent secondary hepatic lipidosis. Antioxidant treatment, high-dose vitamin E, 0.3 to 0.5 parts per million dry matter selenium in total ration, and consider vitamin C supplementation. Control head position to prevent additional swelling of the head and tongue. Muscle relaxants may aid relaxation of trismus. Control cardiac arrhythmias, ventricular tachycardia may require first-line therapy with lidocaine or magnesium sulfate. Repeat echocardiography to monitor circulating volume and cardiac function. Antibiotic coverage usually only indicated in high-risk patients and those with aspiration secondary to oropharyngeal dysphagia. Deficiency is readily prevented by daily dietary supplementation, which induces peak plasma and blood concentrations within 28 to 112 days after supplementation commences, even with minimal change in plasma glutathione peroxidase. Supplementation of pregnant mares is recommended throughout gestation to optimize selenium status of the developing foal. It has been demonstrated to reliably increase muscle and plasma selenium concentrations in mares and the foals they produce, as well as increasing colostrum selenium concentrations. Reference values for whole blood selenium concentration in mature horses may vary somewhat between laboratories, but a range is consistent with values that have been applied in the last 3 decades and likely promote optimal function. The origin of reference values for whole blood selenium values in foals is less clear, with a large study employing relatively disparate values in foals under 10 days of age and for horses over 10 days of age. Foals from supplemented Mares in a longitudinal trial had plasma selenium values when Mares were receiving 0.5 to 0.65 milligram per kilogram dry matter in the ration during gestation.
Thank you to our listeners. From Vet Neuro Jar, keep those minds inspired, hearts light, and tails wagging.